Hello and welcome to this presentation, Radiographic Assessment of Archaeological Long Bones, Experiential Learning on Technique. I am James Elliott. I'm a lecturer in Diagnostic Radiography from Canterbury Christ Church University in Kent, and this research was done in collaboration with Adelina Tuaka, an osteoarchaeologist from Canterbury Archaeological Trust. The research was funded by the College of Radiographers Industry Partnership Scheme, which supports radiography research. And this presentation was presented at the British Association for Biological Anthropology and Osteoarchaeology conference at Teesside University 2021. It's great to be back at Teesside University, although, it's online. I did my Masters in Forensic Radiography here and completed in 2019. It was an entirely online course, but I came to visit the campus, had a look around, saw the wonderful new buildings there, and I recommend a visit. So why use X-rays with human dry bones? There are a variety of reasons. To aid the diagnosis of pathologies and trauma, to demonstrate the extent and characterization of pathology and trauma that can't be seen with the naked eye, for the assessment of dental status and then therefore give an indication of age, the assessment of bone density using something called photodensitometry, the assessment of bone loss using radiogrammetry, and to demonstrate preservation status or taphonomic changes. This could be from soil infiltration, leaching of minerals, or the opposite, mineralization. X-rays are complementary, not a replacement for visual inspection. Adelina and I had different research goals, but we both needed to undertake a radiographic survey of long bones shown on the screen. I used it as a reflective exercise for radiographic technique and workflow process of human dry bones, and I wanted to generate recommendations for archaeological and forensic practice. Adelina, on the other hand, was writing for her master's thesis, and she wanted to identify Harris lines within an archaeological population, i.e. where growth has stopped and started within the bone. And she wanted to test a method for estimating the age of Harris line formation, i.e. the age of nutritional or pathological insult. Now, this presentation is not so much about her Harris line investigation, but I'd be remiss of me if I didn't show you an example. This is actually an example, as you can see, from a modern person. Harris lines aren't just of a historical archaeological nature, and we can see these sometimes in patients in practice. The horizontal lines going across for this patient show times where there was a cessation and then the starting again of bone growth, typically seen in long bones. The sample that we used for this research included 92 medieval and post-medieval skeletons from Monk's Cemetery within Abbey Church and the Cathedral of St Albans. They were excavated by Canterbury Archaeological Trust in 2017 and 2018. There were 155 skeletons available, but 92 were selected for the radiographic survey due to preservation status and the availability of the long bones. And this ultimately included 16 juveniles and 76 adults. Ethical approval was sought, but deemed not necessary as the imaging was non-destructive, non-invasive, and the age of the remains fell outside of the Human Tissue Act. This is my thought process for this project. I am a diagnostic radiographer, but I've also done a degree in archaeology in the past, and I wanted to try to merge the two together. I spent the last 13 years x-raying the living in the clinical environment. The radiographic technique that we abide by is based upon extensive research and guidelines for best practice for patient care. I began to wonder then, are there similar guidelines in archaeology, and what research has been done? The CoRIPS project provided funding to buy out NHS time to provide travel costs and a little bit of money for equipment. It involved a literature review of current research for dry bones and confirmatory research to x-ray some bones between March and April 2021. As I found out from the literature review, there is really very little research to do with how we should be x-raying bones from an archaeological context. And the recommendation of this hoped to address that to some extent. But what is radiographic technique and what are the workflow processes involved? Radiographic technique relates to X-ray exposure values, kV and MES, that's tube voltage, the power, the penetrating power of the X-ray beam, and MAS, the tube current, which is the quantity of X-rays. It is the distance between the tube and the detector. The radiographic views, whether it's anterior, posterior, medial, lateral, which are the standard views, or a multitude of different other radiographic views for parts of the body, as shown in Clark's Positioning and Radiography, a tome, a bible of a book for radiographers, and there's image processing options as well. The workflow process is a bit more simple. It's the team roles, it's the logistics of getting it done, and how you would record the data involved. And on this slide, we can see the X-ray console, where we would select the exposure values, the X-ray tube, which we would position over the bone, the sponges, which we would use to put the bones into the correct radiographic position, and then lastly, an example bone shown in an anterior, posterior, and a medial lateral position. Just to illustrate the point, these are X-rays of a femur in the anterior, posterior radiographic view, and then the medial lateral view as well. The methodology, how did we do it? I had funding for 10 working days to complete the imaging. The workflow process was to be determined. That was part of the whole reason we're doing the imaging, was to learn about how we would fit in together as a team. The equipment, though, we did know. We had Siemens Multix top unit with an AGFA digital detector, meaning we can X-ray bones rapidly without needing to process the images. It came on the screen within a couple of seconds. Radiographic markers were used, left and right, shown more or less in the middle of the screen, and radiolucent sponges to position, shown bottom right of the screen. An aluminium step wedge was used in most X-rays for quality assurance and for maybe photodensitometry experiments or research later on down the line, so not inherent with this research. Radiographic views for Harris line detection, we decided to use both anterior, posterior, and medial lateral views, so 2 views from 90 degrees as recommended by Premio et al. 2016. Results by the numbers. Only 5 days were required to image all the long bones instead of the 10 that were funded. This is because of the speed of a digital X-ray room and having an experienced osteoarchaeologist on board. 502 X-rays were generated for 426 long bones, plus some other bones of interest that showed weird pathology. For those that are interested, Harris lines were seen on 50 individuals, so that's 56% of the sample, and about 70% of which were visible on the distal tibiae. For me, this was the true benefit of the research. We discovered a workflow process. The team fell into a natural division of labour according to their area of expertise, and it formed a cycle of bone selection and imaging, starting with Adelina, osteoarchaeologist. She picked up one of these skeleton boxes, cross-referenced it with the Excel spreadsheet which she had pre-populated to show which boxes had which bones available for imaging. Then she would pick out the bones and place them upon the detector. Me, the radiographer, I would check the bone, make sure it's the correct bone, the correct side, so left or right, and the correct orientation. I would then perform the imaging and then write down the imaging that I'd performed as a written log, and then I would process the images on the radiography system before going back to Adelina, who'd pick up the next box. Fail-safe checks were integrated to reduce errors and highlight discrepancies. The Excel spreadsheet that Adelina had the same data as the written log that I had. It had the same skeleton number, it had the bones imaged, the radiographic views taken, and mine had the exposure values used. And if there was a problem at any point when we were looking at our data, we can work backwards to identify those issues. We also had the thing where both of us were looking at the same bones together to identify the correct anatomy, the correct laterality, left or right, and the correct orientation of the bones when we image them. This is particularly important for fragmented remains, where it's very difficult sometimes to discern which way round a bone should go. With regards to radiographic technique, for successful imaging, judicious use of radiolucent sponges to position the bones was essential. An example is shown bottom right and top right. Radiographic markers were also essential for confirming the laterality, meaning it was a physical reminder, a visual physical reminder. When you put the bone down on the detector, the left bones or the right bones should go on the left and right correspondingly. It was a useful visual reminder for Adelina and myself. The anterior posterior view was easy to perform on all the bones. But the immediate lateral view was hard and sometimes impossible if the bones were fragmented. Any more than one break, so it had 2 or more breaks, it was pretty much impossible to perform a medial lateral view. Image processing, whether it's rotating, cropping, adjusting the contrast and brightness, or annotating the imaging, was needed, but it was time consuming. It took so much time, and that really was one of the limiting factors of our speed. Here are some examples of using the sponges to perform a medial lateral view. The femur on the left, the distal end of the humerus in the middle, and then the humeri on the right hand side. You can see that I've got the markers, left and right corresponds to whether it's a left humerus or right humerus. And here's some examples of the bones being placed in an anterior posterior view, the femur on the left, the humeri in the middle, and the radii on the right hand side. In most cases, a sponge was not needed to obtain an accurate radiographic view. Accurate radiographic imaging of any bone with more than one break, like this one's got 2 breaks, it's in 3 pieces, was really down to patience and precision use of the sponges to achieve a good imaging. And then you have to question yourself, what am I going to find? Is it going to be of any use to me? But it is possible to have good imaging, it just really takes a lot of effort. And here is the same bone shown in the medial lateral position using the sponges to achieve what is quite a good position radiographically, but took a long time. For exposure values, this is what we found out. In the hospital environment, patients have greater density due to soft tissues, and we use customized exposure values for each body part. Some examples shown there. The idea is that we want to reduce the dose as much as possible to reduce cancer risk. But with dry bones, there's no soft tissues, no concern for cancer. 55 kV, the tube voltage, provided adequate penetration for all the different bones. So we would reduce slightly for juveniles. Generally speaking, increasing the tube current, the MAS, would increase the image quality, but too much would have image burnout, artificially shown here in the bottom right. So for our digital radiography system, bearing in mind that all systems are different and it is different with chemical film as well, 55 kV and 5 MAS at 100 centimeter distance was ideal for us to produce optimal imaging for all of the different long bones, irrespective of their size, although once again we did reduce slightly for juvenile bones. Right there, now conclusions, now recommendations from this project. Do you want to x-ray a whole graveyard like we did, assuming that you have a good research goal or question in mind? Get the team together. 3 we say is ideal: a radiographer, an osteoarchaeologist, or someone with good knowledge of bones, and 1 other for photography, image processing, or as a runner. Use of a digital X-ray system. This is because of its speed, the ability to manipulate the images easily, and data sharing. You can export and send it via the internet. Consider the logistics. How many skeleton boxes can you fit into a hatchback or whatever vehicle you have available to get it from where it's been stored to the X-ray room and then back again? Use of appropriate radiographic technique for your research. You need to be able to produce reliable and reproducible X-rays for robust results. And then radiolucent sponges and radiographic markers are a must for the best quality images. And lastly is to incorporate fail-safes to minimize error and highlight mistakes, because if you have a problem with your data, you need to be able to work backwards to find out whether it's affected all the data or just a few of them. I'd like to say a big thanks to all those who contributed towards this project: Canterbury Christchurch University for letting me use the X-ray room, Canterbury Archaeological Trust for letting me have access to the skeletons, and of course the help of Adelina, and lastly the College of Radiographers for allowing me to have time to do this research.